Dear friends, dear colleagues, thank you once again allowing me to join the conversation at your Congress. Today we will talk again about the nitrosamines in sartans and hydrochlorothiazide as key factor for melanoma or melanoma precursor lesions. First of all, let me declare that we do not have any conflicting interest, and this research did not receive any financial support. And we present a 77-year-old Caucasian male, phototype 2, which visited our polyclinic for dermatology, venereology, and dermatologic surgery in February 22 with a primary complaint of a pigmented lesion on the left cheek, as you can see it on the image, first noticed in January 22 and which increased in size and discoloration over the last 2 years. From the anamnesis, the patient has arterial hypertension, diagnosed 11 years prior. This has been treated with olmesartan hydrochlorothiazide for 2 months in 2018, followed by irbesartan hydrochlorothiazide for 3 months additionally in 2019, and then with telmisartan hydrochlorothiazide about 2.5 years. As a whole, we can mention that the patient has received sartan hydrochlorothiazide combination from the end of 2018 to the beginning of the appearance to the beginning of 2022. So that the past medical history of this patient is also very interesting. He has in 2014 his past medical history revealed the data for malignant melanoma on the left arm, which has been surgically removed with an overall margin of 2 cm without the performance of a sentinel lymph node biopsy. And the subsequent histopathological verification reveal a tumor thickness of more than 2.5 millimeters, so that we have an intermediate thickness cutaneous melanoma without invasion of the lymphatic vessels and venous vessels, and so that we have it has been staged with T3A N0M0 and no evidence for disease progression on imaging studies, meaning here SPECT-CT and PET scan on the 2015, 2017, and 2019 and 22. Further parallel surgical interventions were also conducted in the past, including excisions of the dermoepidermal nevi without cytological evidence of dysplasia, but this was long ago and before he has taken the medication with Sartans. And 2018, you can see the blue arrows. These are the scarring. This is the scarring after the surgical interventions, that were localized on the left pectoral region and back without any further signs of malignancy or imaging biopsy. Additionally, 3 completely new pigment melanocytic lesions with some atypical clinical and dermoscopical features. You can see on the image the red arrows were observed during the dermatological consultation at 2021. The main reason that the patient visited our ambulance were the single superficially spreading asymmetrical hyperpigmented lesion on the left buccal region, which has had an uneven borders, clear demarcation with varying shades of discoloration, and the lesion was also suspected for superficial spreading melanoma or lentigo maligna type. As we have already mentioned, the other lesions which were practically new were localized on the scapular region, infrascapular and lumbar regions. They have a positive ABCD criteria with asymmetry, irregular borders, discoloration, and diameter more than 6 mm. and they were diagnosed as melanocytic nevi with some signs of dysplasia, appeared in the last 2.5 years after the start of the therapy with Sartans and hydrochlorothiazide combination. What we have done in that case, with the suspicion that telmisartan and hydrochlorothiazide might probably contribute to the development of these melanocytic precursor melanoma lesions, the medication was discontinued and an alternative treatment regimen of torsemide, moxonidine, and flecainaztat was prescribed with a good blood pressure control. The facial lesion was removed under local anesthesia in the form of elliptical excision with a primary security surgical margin of no more than 0.1 to 0.3 cm, and as histopathology revealed the diagnosis of melanoma in situ, lentigo maligna type, a secondary excision with an additional surgical security margin of complete 1 cm in all directions was performed with clean resection margins. Histopathology of the three melanocytic nevi in the back confirmed dysplastic melanocytic nevi in 2 of them with clear resection margins, and the postoperative outcome was positive with good signs of wound healing for all 4 lesions. Once again, we want to show the first operation under local anesthesia in the cheek area where the lesion has been removed with a narrow surgical margin. Here you see that there was bleeding, of course, of this procedure. This is directly the postoperative image after the removal of the lesion. After 10 days, you see that there are some problems in the wound healing and the small secretion, which has been overcome with antibiotic therapy and local wound dressings. Here you see the plan for the second excision, but first of all you can see the difference between the 2 images. On the left image you see before the antibiotic therapy, and on the right image you can also see the improvement of the scarring after the lesion has been treated accordingly. Additionally, in this surgical session, we have removed 3 of the lesions located on the back, and as you can see, we have started here with additional surgical security felt with 0.7 or 8 centimeter, and in depth you see that the lesion has been removed very carefully so that also the underlying tissue has been removed and the excessive bleeding has been stopped with an electrocautery. And here you can see the direct postoperative result for the first lesion located on the face over the left nasolabial fold, and the 3 additional lesions on the chest. Here you can see the patients several months after the lesion has been treated and after the stitches has been removed. And here you can see it, I think 5 or 6 months after that, so that it looks like much better. Nowadays, here is 1 year after the surgical excision. You can see that there is fast no signs of this scarring, and the patient is in a good health shape. Why we want to present this case? First of all, there are 2 problems. As you know, nowadays we know that nitrosamines are probable human carcinogens, but nowadays probably not a probable one, but surely a human carcinogen. And nitrosamines in sartans and in nitrosamine and hydrochlorothiazide might contribute to melanoma development. about this, exactly about this topic, we would like to discuss the results and the data in 10 good international papers in order to find out is there a connection between the drug intake, nitrosamine contamination, and melanoma development or the development of melanoma precursor lesions in the face of lentigo maligna, melanoma in situ, and dysplastic nevi. First important questions is, are nitrosamines in elevated concentrations in blood medications really dangerous? I am showing here a paper which is titled Estimated Cancer Risk Associated with Nitrosamine Contamination in Commonly Used Medications, where different theoretical models about this contamination has been presented and the risk about development of different type of cancers have been suggested. All these findings suggested then that nitrosamine contamination in drugs that are used long term can increase cancer risks and pose a serious concern to public health. And accordingly, the results of the study for the increased amount, especially of NDMA in valsartan products, indicate that the risk of developing cancer increases to between 40 and 226 additional cases per 100,000 population, and for NDA from 20 to 48 additional cases per 100,000. These calculations were made only when using one nitrosamine in one medicinal preparation, and as you know, there are multi-contaminations with up to 3 nitrosamines in one tablet, so that it is probably only the top of the iceberg. Second important paper, it is a paper published by well-known researcher and cardiologist, Professor Pahi, which has published his latest meta-regression analysis of randomized trials about the risk of cancer with angiotensin receptor blockers, or so-called Sartans. And he came to the conclusion that this data for first time in the world literature reveal that the risk of cancer with IRBs, and especially lung cancer, increases with increasing cumulative exposure to all these drugs. The excess risk of cancer with long-term IRB use has public health implications. And as you can see, the detailed analysis, there was a highly significant correlation between the degree of cumulative exposure to IRBs and the risk of all cancers combined, not only for skin cancer, so that we have really a very serious problem. When I come back also to research from the same authors from the year 2010, where he has focused mainly on telmisartan and its association with new cancer diagnosis since 2002. The first publication is also published by Pahi in Lancet Oncology in 2010, and at that time he has also shown that there is some risk, even a minimal one, to develop cancer when you have been treated with Sartans or angiotensin receptor blockers. However, we have not to forget that at that time the problem with nitrosamine contamination was unknown. It only became relevant in 2018 through the FDA alerts. At the moment, even these nitrosamines are in permissive regime by the EMA, which pose, of course, serious questions and problems. Here is the first paper of Pahi, where he 13 years ago, he published his first meta-analysis of randomized control trials, which suggests that IRBs are associated with a modestly increased risk of new cancer diagnosis, so that we have this alarming sign already long time given. What about not the nitrosamines, but the active substance? We know that there's some experimental data. These experimental data are very, very interesting. There are several papers focusing on them, and they share the thesis that losartan could also promote mV3 cell adhesion and invasion in melanoma cells, so that from that point of view, we have to be very, very careful, because probably nitrosamines could trigger the development of neoplastic seal, but there is even a small possibility that the active substance could independently trigger the metastasizing process. Interesting paper from Schmidt et al. About the use of antihypertensive drugs and the risk of skin cancer, published also in 2015. And here the focus is again the ARB's long-term intake at low concentration bear the risk of development of melanoma of about 53%. And also the ARB's long-term intake at high concentrations or dose bears the risk of developing melanoma at 44%. That means that the risk of developing malignant melanoma is not affected probably by the dose of the medication taken, and probably this could be a possible contamination. There is no data in this study on whether the active substance which has been used has contained nitrosamines, because at that time or at that point there was no data about that. One of the most interesting papers is also the match cohort study from Beatrice Nador and colleagues, and they show that both medications, when exposed to this medication as monotherapy, we have risk to developing melanoma between 225% and 24%, and the monotherapy with thiazides bear the risk of development of melanoma between 182% and 206%. These are alarming data. Even the study has some weak points when focusing especially on the adjusted factors which has been included. Another interesting paper, it is from the American Academy of Dermatology, is showing that the monotherapy with Sartans bears additionally the risk of 221% developing melanoma. That means more than twofold increased melanoma risk, and about 2.03% or 200 or twofold melanoma risk for thiazides as monotherapy. Worryingly, 5 years later, there is a lack of prospective studies that are equivalent of irrefutable evidence of cause-effect relationship statistically. Probably one of the reasons about that is that from ethical point of view, it could be not started a study with tablets which contain carcinogens in 20 to 200-fold increased concentrations. HCT, we know that hydrochlorothiazide is a longly discussed medication, especially for its photosensitizing effect. And additionally, we know that nowadays there is a nitrosamine contamination in these medications given us as information as Pfizer, so that probably these elevated concentrations could significantly contribute to the development of melanoma and also non-melanoma and other cancers development. We know also that hydrochlorothiazide and risk of melanoma subtypes. For some subtypes of melanoma, especially for the lentigo subtype, we have a risk about 57% for developing this. So that there is a recent report of an association between high use of HCTC and increased risk of the lentigo subtype of melanoma. Contamination, one of the latest study with nitros NDMA has been a NDMA contaminated valsartan and non-contaminated valsartan has been compared in study, and a total number of 1.4 million subjects without any history of cancer were included, and the data were surprisingly, of course, for the following one. This very new study published in the Journal of American Heart Association in 2022 was the largest to date to examine cancer risks associated with exposure exactly to NDMA contaminated valsartan. And these findings suggest a slight increased risk of liver cancer and melanoma in patients exposed to NDMA in regularly taken medications, confirming also our observation. The question remains, is NDMA related to melanoma officially? We know that independent where NDMA is available, there are some lawsuits, and this lawsuit, especially for ranitidine and nitrosamine contamination, has not been accepted. However, which were the patients which were included in this lawsuit? These were people who has taken ranitidine and has developed various types of cancer. And the FDA Drug Watch Bulletin has given this cancer, and here you can see cancers that qualify for Zantac lawsuits were stomach cancer, prostate cancer, ovarian cancer, and melanoma. Even we do not have even one publication in the literature about melanoma development under ranitidine. This, of course, is very interesting, because that means that FDA and drug authorities and controlling organs have different information about the adverse effects, which has been not published in the scientific literature. And initially, there has to be melanomas after ranitidine, even not a published one. After that, several months after that, or probably 1 or 2, the cancers that qualify from Zantac has been changed from 10 to 5 without any explanation, which seems to be very strange. Here once again, the data were in 2022, Pfizer voluntary has performed a nationwide recall of quinapril hydrochlorothiazide, quinapril and hydrochlorothiazide tablets. So because of the nitroso-quinapril content, a special nitrosamine. As a whole, we can conclude that whether NDMA is found in metformin, ranitidine, quinapril, hydrochlorothiazide, or different sartan-containing medication, it has already a proven carcinogenic effect, and we report on a patient who took potentially nitrosamine-contaminated high blood pressure preparations, Sartans, olmesartan, irbesartan, and telmisartan, in combination always for HCT, hydrochlorothiazide, who subsequently developed lentigo maligna and 3-dysplastic nevi. The amount of the data linking the use of hydrochlorothiazide alone or in combination with sartans and the development of melanomas or their precursors is worrying one. Given the additional disclosure of pharmaceutical companies about the existing elevated concentrations of nitrosamines in these two classes of antihypertensive drugs, the establishment of a causal relationship between the intake of a particular carcinogen and the development of a tumor or tumor precursor lesions requires careful and detailed scrutiny. The extent to which sartan HCT used and the occurrence of lentigo maligna, especially when shared data points in this direction, remains unclear. However, in clinical practice, it should be highly recognized and analyzed. We have the possibility to publish this paper in the highly reputable Portuguese Journal of Dermatology and hope to share very, very soon our new data. Thank you for your attention.